Good morning.
Technical difficulties.
Wait, we're muted.
I hear you.
I know. I hear you. Can you hear me?
I can, yes.
Okay. I'm sorry. I had the other computer, but we ended up here. So I can't get to the other computer. I apologize.
Here we go.
Here we go.
Technical difficulties this morning, everybody, but here we
So
are.
sorry. Hang on. Sometimes mistakes do happen, but we roll with them. Thank you, Dr. Rosensweet, for that. Good morning.
Good morning.
And good morning to everybody. I have our questions, and let us get started. Thank you for being here. Question number 1 comes in, and welcome everybody too, and thank you for saying, V, that you hear us. Could you please talk about cortisol and how it relates to our hormones? Do people take cortisol? I know it primes all the other hormones, but I'm wondering if a woman has too high or too low cortisol, does this affect the way that hormones are going to work in her body?
Well, cortisol comes out of the adrenal gland. That's where it's produced. And it's the most important hormone in our body in the sense that if we don't have adrenal glands, we don't get to live. Cannot remove someone's adrenal glands. We can live without any of the other hormones in our body. We can even live without thyroid hormone. We'll be in bed most of the time.
Right.
And live, but not without cortisol. And because of that, it's highly protected internally. All kinds of priorities are given to the production of cortisol. Cortisol is made out of the same cholesterol, pregnenolone that other steroid hormones are made out of. But when there's limited resources, the metabolic pathways are going to favor the production of cortisol because it's the highest priority.
Right.
It does a zillion things like all these powerful hormones do. And one of them is it's crucial for sustaining blood glucose and so many other functions. It mobilizes for fight or flight, biochemistry. It does hundreds of things in the human body. We love it. And if someone has an excessive biological response to stress, day after day after day, year after year after year, well, what the biology of the stress response does is it calls on the most powerful biochemicals in our body so that we can fight or flee. And it calls on cortisol and adrenaline. They're at the vanguard of the biochemistry of responding to saber-toothed tigers or challenge cash flow. Both of them work.
I wonder if those saber-toothed tigers use cash. Haven't asked one lately. I might borrow some.
Good point.
Yeah.
The cortisol has so many normal functions in the human body, and yet, like so many hormones, it can be recruited and it can be very effective in the saber-toothed tiger fight or flight response. For example, the brain and the muscles need a tremendous amount of energy source to be able to fight or flee, and cortisol is one of the principal biochemicals that mobilizes the fuel, the glucose from cells. It'll even participate in the breakdown of muscles to get and turn the muscle protein into amino acids and turn the amino acids into glucose. Gluconeogenesis, powerful capabilities.
I like that word.
Yeah.
Yeah.
The cortisol is very basic for all functions, and when it's recruited for the fight or flight, it's capable of redirecting energy for fight or flight. For example, it will suppress the immune system because the immune system, although we're not cognitively aware of it, the immune system requires a tremendous amount of our energy. I mean, think about it when you get the flu. You're in bed, you're exhausted because the body's energy is being diverted to support the immune system.
Yeah, we don't look at it that way. We just look at it like we just feel sick.
Exactly.
Yeah.
And cortisol is the principal biochemical that suppresses the immune system. This is capitalized on in medicine when there's excessive amount of immune activity as occur in autoimmune inflammation. Some version.
Uh-oh.
So that's some things to say about cortisol. Now, long-term stress, and what all of us know about human life is it has periodic, small, medium, large stresses in it. And the stresses are part of nature as rain and snow and air is. They're very much a part of life. The part that where stress gets challenging is if we have an excessive or inappropriate response to it. If, for example, you're watching your bank account dip and you inaugurate fight or flight chemistry to the extent that you think a saber-toothed tiger is coming, that would be an excessive response. Or if your partner, someone you live with, for example, or are intimate with, looks at you sideways with not the most beautiful, loving face they've ever looked at you at, if you get all upset and bent out of shape and take it personally, rather than pause to consider that maybe they're having a bad day.
The stock market crashed.
That's capable. Not even that. I'm talking about subtle stuff here.
Yes.
I'm talking about you meet and greet your spouse after you haven't seen them all day, and they have a very sour look on their face, and you immediately get offended and you get angry because they're not giving you the amount of love you think you want and need, and you start having a reaction to them. That too is fight or flight. That's called an inappropriate response to stress in your life, and you don't even know what's going on. They may have just seen or heard about a friend of theirs that got in an auto accident or something, and they're extremely stressed by it. So I'm talking about the possibility of inappropriate and excessive response to stress. Cortisol and adrenaline are going to be brought into that. as are other hormones. And if you keep doing that day after day after day, if you're not skilled at emotional and mental and life stress, and you know how to address it quietly and successfully with wisdom and skill, you're going to keep on calling forth that cortisol. And you're going to keep on tiring the gland that you're putting an excessive demand on, that adrenal gland. You're going to keep on putting excessive demand on it. And over time, it can't keep up with it. So this new word creeped up in the course of my medical lifetime that I had never heard in medical school. It was called adrenal fatigue, implying that maybe the adrenal glands are, quote, tired. I don't know that that's the accurate word, but the adrenal glands can definitely get to the point where they're not producing as many of their hormones because they just don't have the oomph anymore to do that because they've been overtaxed for too long. Cortisol, like I was saying earlier, is such a high priority that it's going to be the last to go. The adrenal gland is going to call on other hormones that can fuel fight or flight, like a woman's androgens, for example, or a man's androgens, the king and queen of which is testosterone. So testosterone is going to get recruited for fight or flight. And women can quite easily have diminished libido from long-term chronic stress that they are not dealing successfully with. I keep on wanting to emphasize that. It's all about how successful you deal with the stress and how bent out of shape or not you are. And so what we see in the world of hormones is there's a lot of them, and a lot of them participate in the stress response. We see the ancillary hormones for the fight or flight getting recruited. Oh, yes, cortisol is going to be recruited and elevated in stress. So is adrenaline, absolutely. So are some neurotransmitters. Well, so is estrogen. It's a wonderful stress-free hormone. It's going to be recruited. And a woman's testosterone, like I was just saying, is going to be recruited. So before the adrenal gland really gets reduced in cortisol, when chronic stress, and it's not the chronic stress, it's again how skillful to respond to it or not. When we test women over time, and there's a corollary here with men as well, we see the androgens depleted first. So we see, yes, adrenal fatigue, and we see lesser DHEA, and we see lesser testosterone. Well, testosterone and DHEA also come out of the ovary, especially in a young woman. So we start seeing the androgens depleted, and we see the estrogen depleted before we see major depletions in the cortisol. I'm just talking practical now. You might have, quote, adrenal fatigue, but it may not have touched your cortisol. And as these others get depleted and you get stressed, you do have the option when you're young of putting out more cortisol than its fair share. Your body may put out some extra cortisol just to make up for the testosterone that it can't get the levels of the amounts of testosterone it'd like to have, and it can't get the amounts of estrogen it would like to have. So it'll increase the cortisol. So sometimes you test a young person, they show increased levels of cortisol, or even a perimenopausal woman. Wow, healthy adrenals still. But that's not going to keep up. Like even in young women, if they're overstressed, like Olympic athletes, for example, are doing these excessive training programs, a lot of those women who are in the Olympics are not menstruating.
Correct.
Their stressful preparation programs have called on so much estrogen that there's not enough left over for the menstruation pathway, the female pathway. It's their estrogen's been shunted down the stress pathway, and that'll occur for a while. So getting down to practicality, when women enter the perimenopause, your 30s, your early 40s, most women still have decent cortisol levels. A few of them will have some elevated cortisol levels and some diminished testosterone and DHEA levels because they've taxed the production of these androgens too long. And we'll see diminished estrogen levels, excessive recruitment of strong biochemicals to support the fight or flight response in lieu of having excellent emotional and mental and choosing and commitment skills that allow whatever is going on, that you do a good job with it and you don't get bent out of shape, which never helps you do the stressors in your life better. It always makes it worse.
Most times.
Some women in the perimenopause have normal or even slightly elevated cortisol. And these days, God, the majority of women are entering the perimenopause with diminished testosterone, diminished DHEA, diminished estrogen. And how do they experience that? They used to have vital libido in their 20s. In their 30s, it was changing a bit. And in their 40s, their libido's a little bit declined. And their decisive ability to make decisions, decisiveness, their motivation's a little bit declined. It's a little harder to get to the gymnasium than it was when you're in your 30s. But I want to keep returning to cortisol. Cortisol in the perimenopause can be normal or slightly elevated. Body's going to do everything it can to divert production resources towards the preservation of cortisol. Occasionally, in a perimenopausal woman, you'll actually see a low cortisol. Whoops. That's a very stressed person. And if you see a low cortisol in a woman, 9 times out of 10, you're going to see low estrogens, low testosterone, low DHEA as well. Well, let's go into the menopause. A lot of women are entering the menopause. They certainly, by definition, are going to have low estrogen, low progesterone, very low, very, very low. And most of them, certainly by 3 years into the menopause, all women are going to have low testosterone. Most of them are, even anyway, because they've taxed their testosterone producing abilities. And then the question is, 3 years into menopause, are they going to have low cortisol? Most are not. They're going to have decent cortisol, maybe even relatively normal cortisol, no matter how stressful their lives are. In my experience of testing women, most are going to still have some decent cortisol. And then there are some who are not. There's some women in the menopause, again, even in the perimenopause, but some in the menopause, that they're going to have cortisol that is not okay. In some women, we're going to see evidence that it's lower than it ought to be. Oh yeah, this is the most common thing. We see in the menopause, if there's going to be cortisol issues, we see the cortisol lower than it ought to be for optimal health. And the wonderful thing is, we don't have to do anything about that, in that we don't have to treat with cortisol. If we treat with the proper estrogens, biased, progesterone, and testosterone and DHEA, within a relatively short time, we're going to see the cortisol recover all on its own. We never have to treat with the cortisol, even a woman who's got low corticosteroids. And that's going to happen 9 times out of 10. Even if a woman is in menopause or even in the perimenopause with low corticosteroids, notice I'm using a new word here. I'm no longer calling it cortisol. I'm starting to call it the family that cortisol is in. The cortisol is the queen of the corticosteroid family. We see evidence of low corticosteroids. We're not going to treat with corticosteroids. We're just going to treat with the 4 ovarian hormones. Those corticosteroids are going to bounce back 9 out of 10 times, maybe 95 out of 100. And we're going to see them restore, and it's fun. It's rewarding to see.
I was going to say, it's a beautiful thing. Yeah, absolutely.
And then in a certain small percentage of women, we're going to need to treat with PROTAC right away. It's just their numbers are way too low. They're way too tired. They have other signs of low cortisol. They're not functioning properly, and we're going to need to treat right out of the gate the CORTEF. We do that. When we do that, we only do it for a certain period of time. We don't use high doses. We don't need high doses. In fact, I like bioidentical cortisol, commercially known as CORTEF. The highest I ever have gone is 20 milligrams. I divide that to 10 in the morning with breakfast and 10 with lunch. That's the highest I've ever gone. I might not start there. I may start with 5 or 5 and 5 or 10 and 5, work our way up. But it's very unusual that we'll actually do that. But there's in cases where women are not well and we're having trouble balancing the other hormones, we'll start right out of the gate with all those hormones, the 4 ovarians plus cortisol. I mentioned the word corticosteroids.
Yeah.
Every hormone we're talking about, you may say estrogen, but we really want to talk about the estrogen family, because there's a lot of aunts and uncles and mothers and fathers and cousins.
Few who are married in.
The family. This is a whole family. The whole mishpacha is involved here. And the active hormone in the cortisol family, the most active is absolutely cortisol.
Mm-hmm.
But there's metabolites, and we add up those metabolites. We look at 3 of them, we add them up. They're a very important indicator of how the family's doing. You could have a relatively normal cortisol, but you could have low metabolites. That would mean that family is depleted, and we want to pay attention to those low metabolites, because that may be what determines us to treat. You might see a low normal cortisol, but you might see very low cortisol metabolites. That metabolites are what the hormone becomes in the process of being utilized.
Right.
Very low metabolites. We'll say, you know what? There's the story. They're too low. We're going to treat, even though cortisol is reasonable. So, yeah, there's some things about cortisol. The other thing that plays into this is thyroid. Sometimes thyroid hormone is also low. I mean, when the fight or flight is raging for short, medium, or long periods of time, and the person isn't responding effectively, I know it's hard to respond to stress. I'm not saying it's a piece of cake to respond to stress, but I am saying there are tools, there's information and tools around with your own emotions and your own consciousness and your own ability to choose, that make whatever stress is going on a heck of a lot easier. Doesn't mean you're not going to feel. No, but you can be so much more effective with it and successful. That's what you want. Stressful situation, you want to respond in a successful way.
Absolutely.
So again, they all matter. And the other thing I'd like to say about cortisol, if you don't have these tools and your fight or flight response is raging and you're gaining weight, one of the reasons you're probably gaining weight is because you've had elevated cortisol levels, because you've asked your adrenal glands in your ovaries, listen, we need more cortisol. So you see your adrenal glands, your ovaries put out more testosterone, DHEA. I mean, really, what you're asking is, we need more flight or fight biochemicals. So your adrenal glands put out the high levels of cortisol. Your ovaries put out high levels of testosterone and estrogen as long as they can, and DHEA. Your thyroid puts out elevated levels of thyroid. And that's what you do for as long as you can. And then they all get depleted. So sometimes, even in the realm of cortisol, you can't even get it corrected if simultaneously you're low in thyroid. You got to get the thyroid corrected as well. Now, to someone who has gone to 82 million years of training in the healthcare profession,
I know someone like that.
That's what it seems like when you're in there.
No doubt.
And you've got a medical degree of some sort that allows you to prescribe, and you've taken this on as a specialty. It doesn't have this outrageous complexity that I'm presenting here on FaceTime Live. especially if you get into functional medicine, which is very important to get this level of detail. This is bread and butter. This is your daily bread. I guess that's not a politically correct term. This is your daily vegetables.
My broccoli.
Yes, this is your daily broccoli. This is part of what you do, and it's very entertaining. It's very amusing. It's and it's fun to correct these things. It's really fun to correct them because you identify them and you give patient what they need and they feel better. That's really
The most amazing
that's the
feeling
biggest. Yeah, that's the biggest joy of medicine.
ever.
You do the right thing and someone says, "Gosh, I feel better." That's my favorite sentence on the planet.
I have to twin up with you on that one. It's my favorite one too. It's a good feeling. It is.
And there's tools to assess these corticosteroids. And I think that's the final things I want to say about them is a standard blood test done in the morning of cortisol is not going to tell you the story. Your body may have enough oomph to at least do that because that's the most important output time for cortisol is in the morning when you're getting it all going. So people are able to show up with a normal fasting cortisol levels, but endocrinologists are not going to accept that.
Yes.
They're going to say, "Yeah, we need a little more definition here. This person's too tired. We're going to figure out, we're going to do an ACTH challenge test, and I'm not going to go into this, or we're going to do 4 cortisols, 4 serum cortisols at different times during the day." And or this is the one thing where saliva works really well. I'm not a proponent of salivary hormones for assessing ovarian hormones, but saliva works really well to assess cortisol throughout the day, a lot because there's so much cortisol in the body that there's enough in the saliva to really test it well. However, my favorite for assessing corticosteroids, going back to the family, is the 24-hour urine hormone test. And man, do we see it with precision. And so collecting urine for 24 hours tells us overall how much is there really in the family of the corticosteroids. And so we always use that to assess the corticosteroids. Not so for thyroid. I mentioned thyroid because, again, it can play into this. You have long-term stress. You don't want to just look at one thing. You want to look at all. What does stress call for? What does stress demand? It calls for a tremendous output of the most powerful biochemicals that can help with fight or flight. And these are the hormones.
That is right. Yeah.
So when you're dealing with long-term stress and you see low corticosteroids, for example, you want to be sure you got state-of-the-art testing of the thyroid too, because it could be low and you can't. My mentors told me that sometimes you can have low corticosteroids, but you're not going to get them corrected if you simultaneously have low thyroid, or vice versa. You might have low thyroid function, and there's some cases where you're not going to be able to correct that thyroid unless you correct the low corticosteroids that are attending it. And so thyroid we test by blood. We do a fasting, first thing in the morning, water only from midnight on. I'd like to emphasize that for everybody. I mean, I've made that the gold standard because there's enough of what you're testing that is dependent upon fasting. Not everything is, but there's some crucial things are. So just think in terms of next time you're going to get your blood test, make sure that you do it from water fast only. You have water after the preceding midnight. Water only. Water only. Did I say water only? I forgot whether I said water only. I think I said water only.
H2O, I think.
That means no toothpaste.
No,
nothing. Right. None of your medications. No coffee. You go online and you set up an early morning appointment for your blood draw at the laboratory. And you don't have toothpaste because it's not going to give you your best numbers as far as glucose goes. Glucose regulation. This is very important. So
reading, yeah.
There's a few words on corticosteroids. I hope I've when someone is put on cortisol, for example, in my practice, and this isn't going to pertain to every endocrinological low cortisol situation. Not going to pertain to everyone. Endocrinologists are seeing super low cortisols, and I'm not talking about that. I'm talking about these functionally low corticosteroids that do test low. Whenever we put someone on cortisol, we pay a lot of attention to them. We are monitoring them over time. We're doing a 24-hour urine hormone test on them because that's my favorite way to monitor it, because I can see how much they've got while the cortisol is in their body. We're watching that, and we're watching it every 3 months or every 6 months, because they're going to recover. You treat them properly, and they're going to recover, and the corticosteroid is most likely to recover. And we don't want to get into excessive cortisol levels. So we're looking for the time when they're recovering, and that's the time we start gradually reducing their dose. Gradually reducing their dose.
Gradually.
So we do it under guidance. It's not necessarily true of thyroid. Once you start treating with thyroid, you're likely into it for the whole life.
Well, yeah.
You'll be grateful for that. And the other thing I want to mention on the blood thyroid test is you want these tests: free T3, free T4, TSH, and reverse T3. Which gives us a segue into a question that we can ask if you want, Carolyn.
Absolutely, it does, and I thank you for that answer. The question comes in that if a woman has a reading of a high reverse T3, how does she get it down?
Yeah. Let's talk about reverse T3.
Well, you made mention of TSH, and TSH means thyroid stimulating hormone?
Yeah.
Okay, thank you.
And that's the most common screening test. And it's really a pituitary hormone.
Yeah.
The pituitary gland, when it reads that body thyroid hormone levels are low, it's capable of producing a biochemical to stimulate thyroid hormone production. And in so many things in medicine, it's quite elegantly named thyroid stimulating hormone, TSH. Comes out of the pituitary gland. So when the body reads that thyroid hormone levels are low, the body increases the output of TSH. So when you see an elevated TSH, thyroid stimulating hormone, what we know medically is that the patient is low in thyroid hormones.
Well,
That's called an inverse mathematical relationship. High TSH, the patient's body is low in thyroid hormones. Low TSH, adequate or high thyroid hormone levels. It makes sense if there's adequate or high thyroid levels floating around in someone's body, the brain and the pituitary gland go, hey, everything's fine. We don't have to put out an excessive amount of TSH, thyroid stimulating hormone. It's very important that people who are paying attention to their blood test levels, I mean, that's not the optimal way to go. Optimally, you have a healthcare provider that you really like and really knows what they're doing, and they understand these numbers because they were trained in these numbers. But anyway.
So, I mean, if you have a high, which is confusing anyway, especially, I mean, the whole thyroid thing is very confusing until, yes, you do study it and get with that person.
Yeah, it's like anything else, you pay attention to it, you'll figure it out. I was talking about TSH, and thanks for bringing me back to reverse T3. Our bodies are just so incredible. It's just, I can't even ever wrap my mind around of it.
I agree.
Your body, if it sees that you have too much thyroid hormone floating around, it doesn't like that. That's too strong a biochemical to be floating around in your body and having an effect. So your body has a mechanism to change the what could happen around excessive thyroid hormone. It takes the normal T3, which is very active,
Mm.
and it messes with the molecular structure. It changes the molecular structure and makes it no longer functional as thyroid hormone. It takes the free T3 and it rotates actually the configuration of it to the extent that it no longer looks the same. And it's just a minor alteration on paper, but that alteration reversing the normal configuration is what it does. That's why it's called reverse T3.
So does reverse T3 do anything?
It doesn't work like free T3 does. And so it becomes ineffective. Well, it's the body's way of protecting against excessive thyroid hormone. So when does it come into play? It's not a common thing that a human being puts out excessive thyroid hormone. It certainly can be provoked into putting out robust thyroid hormone. Chronic stress that calls for increased energy the thyroid can participate in that by increasing the thyroid hormone output, because thyroid hormones support the function called metabolism of energy.
Right.
And what happens at the core of metabolism of energy is the food you eat gets linked up with the oxygen you breathe in your cells, and that combination causes the production of energy and heat. And that's how you're doing it. Energy and heat from metabolism of what you eat and oxygen. Oxidation. It produces energy and heat. And the main biochemical governor of the rate of metabolism in this case, of glucose ultimately, or even products of fat, the ultimate outcome of this metabolism, of energy metabolism, is increased energy and increased heat. So if you've got too much thyroid hormone, you get too much energy. And it's like people who have too much thyroid hormone, they don't like it.
Mm.
They get nervous, their pulse goes up, their heart beats faster, they get heart palpitations, they get a tremor, a visible tremor. And it feels
They
like
end up in the emergency room.
yes, often enough. And
Yes.
they feel like they have drank too many cups of coffee in the subtle stages of it.
Right.
It's called Graves' disease, and it's an overfunction of the thyroid. And one protection that our bodies have set up for excessive thyroid hormone output is reversing the T3, but that's not effective in Graves' disease. It just doesn't work. You don't get enough of it. But that's where one place you're going to see an elevated reverse T3. So if you see an elevated reverse T3, you want someone who has the skill of an endocrinologist that knows how to test for Graves' disease. The most common way that we see elevated reverse T3s these days is from excessive treatment, where yes, indeedy, someone might have needed thyroid hormone, but no, indeedy, they didn't need that much. They didn't need too much. Well, the body has a way of protecting itself. If you're taking too many thyroid pills, it can take some of the thyroid hormone that you're taking, and it can alter the configuration of it. But, if there's too much thyroid hormone you're taking, the reverse T3 is not going to do it for you. You're going to still be in excessive zones. It can do some of the protection. We do, as a routine, on every thyroid blood draw, our patient goes in fasting. They haven't taken their thyroid hormone that morning if they're on thyroid. They haven't taken coffee. They haven't taken tea. They can't have water. They don't take toothpaste. They don't do toothpaste if we're going to test their fasting blood glucose. or cholesterol or anything like that. You just think, just to make it simple for yourself, if you're ever going to get your blood drawn, go in fasting, water only from the midnight night before. Lots of water, that's good, but nothing else. And we're going to test the free T3, the free T4. These are not the most common things tested unless someone's really been trained in this. Free T3, free T4, TSH, and reverse T3. So if you got an elevated reverse T3, something's not right. You're on too much thyroid, or your thyroid's are overactive and it needs attention and it needs expert diagnostic care.
Thank you. Thank you. The thyroid is a very interesting subject, as is the hypothalamus and the pituitary, which we've discussed. That pituitary that keeps putting out what it puts out. And it leads me into my next question. We have a few minutes left. In regards to this, we're talking about binding. We're talking about reverse T3. So a woman is asking, she says, I'm always taking progesterone to help with my hot flashes. I'm wondering if the sex hormone binding globulin might have something to do with this. I don't react well at all to taking estrogen. It's confusing as I'm not sure how to get my body to cooperate with this estrogen. Taking estrogen is very hard for me to do, as I always feel ill when I try to take it. Maybe I'm binding it all up, so it's not effective for me. Have you ever heard of this?
No. Interestingly enough, for a woman in menopause, I've never seen a woman who doesn't need estrogen. And estrogen can be, it's usually pretty easy to replenish estrogen and get it right. Especially if you really know the dosages, know how to administer it. And so you want someone trained who knows their doses and knows how to administer it. And then some of the time, it's a piece of work to get the estrogen adjusted properly. And some of the time, it's a super piece of work. Not common, but it really takes some adjusting. Now, here's how I heard that question. I'm going to go back to the questioner. She's like, unfortunately, so many women who, with all due respect, are not receiving adequate professional care. In menopause or the perimenopause, and they're coming, if a woman is coming forth with a question like that, this is what I hear. She is not linked up with a professional who's taken on menopause and the hormones involved as a something they really love. They really enjoy it. They've gotten training in it. They're getting mentoring in it even. They're because the vagueness of that question, that's what leaps off the page. Now, I'd like to zero in on what little pieces I can extrapolate from that question. Progesterone's always good. It's a piece of work to get it right. It starts with knowing what dosage forms, whether you're going to give it topically or orally, what you should put, if you're going to do it topically, what you should put the progesterone in. If you're going to give it orally or topically, what are the proper dosage ranges? And you know what progesterone deficiency symptoms look like, and you're paying attention as you're gradually increasing progesterone doses in a process called titration that I explain in great detail in our book, Happy Healthy Hormones, that Carolyn has made available for no charge, the PDF version of it. There is a hard copy readily available, but the PDF version is free. You can just go in there and download it. And we describe in great detail about lots of things about progesterone and other things, of course. So I don't know. Progesterone is very important. Is progesterone likely to raise? I'm only mentioning the sex hormone binding globulin in reference to progesterone because the
Right.
questioner asked about it.
Yes.
I don't know that I've ever seen a case of progesterone being administered in such dosages that it triggers the increase in sex hormone binding globulin because the body's freaked out that there's too much progesterone, so it's trying to bind it up.
Right.
And I could go into what sex hormone binding globulin is, but I may not right now. I just like to see progesterone and sex hormone binding globulin, unlikely to be the provocateur. For example, people hate taking too much thyroid.
Right.
They get so weird. They feel so awful that it's thyroid dosages have this built-in protection mechanism that someone's not going to overdose on thyroid. Because they're just going to feel terrible. So
Right.
they're not going to overdose. Very unlikely that they're going to overdose for a long
Yeah.
period of time. Same with
Yeah.
progesterone. You take too much progesterone, progesterone's the great relaxer. You're going to get too relaxed. You're going to feel like you're drunk, or you're wobbly, or you've taken an overdose of a sleeping pill. So I don't usually see progesterone. I don't know that I've ever seen progesterone dosages for someone who's been taking it for a while that are so high and show up in 24-hour urine hormone tests that are so high that they're capable of raising the sex hormone binding globulin. But other things are capable of raising sex hormone binding globulin. You have mentioned it. Excessive doses of thyroid hormone can raise sex hormone binding globulin. Excessive doses of testosterone in a woman can raise sex hormone binding globulin. Excessive doses of estrogen. In fact, young women,
Yeah.
as I've mentioned many times, a woman's peak ovarian hormone output is the age of 20, plus or minus a couple of years. And if you give a woman that age extra estrogen, the time when she's putting out the maximum she's ever going to put out in her lifetime, the body goes, huh? What's going on here? This is too much estrogen. Well, we have a natural protective mechanism. We'll just bind up some of the excess there. So the normal transporting sex hormone binding globulin protein that's used in normal function, the body just increases the production of it, and the body binds up the excessive estrogen found in the birth control pill. Very elegant. And most women, when they stop the birth control pill, the sex hormone binding globulin, if it ever did get elevated, goes back to normal range. However, it doesn't go back to normal range in all women. So there's some women who are in perimenopause or menopause that actually have an elevated sex hormone binding globulin.
Interesting.
Is that a problem? Very often it's not. So even though in the menopause method, we get a mandatory sex hormone binding globulin in the beginning of treatment, just to see where we're starting off, even if it's a little elevated, we just play with it. We just play with the dosages. We don't get bent out of shape around it. Now, if it's way elevated, as occurs sometimes, it can really interfere with the dosages. Where it really gets us is with the estrogen. It can mess with estrogen dosing big time. So to your questioner's point, is that a possibility that you're having trouble with estrogen because there's an elevated sex hormone binding globulin? The answer is yes, it's possible. It's not super common, but it is possible. So what do you do? Well, here's the job, really. It comes down to your job as a woman to go shopping until you find a licensed healthcare provider that's been trained in menopause and hormones, knows what they're doing, really loves it. Really, it's a substantial part of their practice, or even better yet, they're specializing in it. They're going to understand all these moving parts. And someone who's really trained is right out of the gate. They're going to get a mandatory sex hormone binding globulin. So like in the menopause method, in the first consultation, we have women show up with any blood tests that they've had in the last year. We're not just going to blanket order blood tests. You may already have some decent blood testing. But if that blood test panel doesn't have a sex hormone binding globulin or those 4 thyroid hormone assessments that we mentioned earlier, we're going to send you back to the lab for the grand opportunity of getting your blood drawn
Especially,
to get a
yeah,
sex
that's a grand
hormone binding
opportunity.
to get a sex hormone binding globulin. We want it. We're going to see it. Why is it mandatory? Because it's not a common cause of trouble, but it's common enough that we build it into our basic assessment plan. So to go back to the questionnaire, I can tell you're having challenges getting your menopause regulated. And the most common things that happens in women in menopause is it's not hard to get their menopause regulated. And there was millions and millions of American women who had very little regulation of prescribing going on. They had 1 or 2 doses of an oral estrogen preparation, sometimes connected with a progestin, Premarin, Prempro. They did really well. For a lot of women, it's not a big deal. You go to your doctor, say, I'm in menopause. They say, here, take this, and you're out the door and you're good. Now, that's not necessarily the most elegant or accurate way to address you as an individual or to get all the 4 hormones balanced. Plus, no, it's not. It's a long ways from it, actually. I'm going to say 2/3 of the women that I've ever dealt with, it isn't quite that simple. But the process is pretty straightforward. It's not that simple. You have 4 ovarian hormones, plus you've got the corticosteroids and thyroid. And at midlife, these things are not happening in balance right. These are gone if you're in menopause, and you got these that could be out of balance. So I'd say in 2/3 to 3/4 of the women that I see as a brand new patient, it's a piece of work to get the optimal dose for each individual woman. And that's the other thing. Men and women, we vary as individuals. We might look alike and walk and talk, and that makes us similar. But biochemically, there's big ranges of differences. Just to give you an idea, there's some women, the number won't make sense to you, but the range might. There's some women they really do terrific and 0.8 milligrams of estradiol equivalent a day. There's other women who they need up to 2.6 milligrams of estradiol equivalent per day. And then women fall within that range, 0.8 to 2.6. That's 3 times the lower number. Plus, that's how much variation there is. And there's some women who even go beyond that. So there's tremendous individual variation. And so best case scenario, you go to someone who really understands this, really knows how to guide you through this. So sorry. So sorry. There's people who are trained and know how to deal with this. And that's your job. Find one of those, you gotta have 2 criteria. Number 1, they have some training and interest in this. Even if they don't have training and interest in them, if they're your healthcare professional and they show interest, we can train them. That's what I spend the majority of my professional time doing, is training and mentoring physicians, nurse practitioner, and prescribing or advising clinical compounding pharmacists. That's NPAs. That's what I do. We'll help them get there. But that's what you need, someone who has the interest in the training, or at least the interest and the will to go out and get the training, because there's a lot of moving parts. You could go to an orthopedic surgeon that is actually a medical student. By a senior medical student, you could set a broken arm. Or you could have your appendix removed by a fourth-year medical student. But, oh my God, that's not who you want to be touching your appendix. or your broken arm. You want someone who's gone through a surgical residency, and if it's your broken arm, you want them to have an extra 3 years minimal in an orthopedic surgery residency, because the amount that's known about how to do it right and correctly, it's 8 years. That's well, or at least 4 years, usually 6 years
It's a
beyond
long.
medical school and internship to get good at any one of those specialties. It's usually longer than that.
It is. Right, in my
What's
world.
taken place in those 4 to 6 years additional additional education beyond internship? A lot.
Yeah.
4 to 6 years. There's a lot going on. These are busy people,
Yes.
overworked individuals, because they need the training. Well, hormones and menopause is somewhat like that.
Very
There's
much
so much
so.
complexity to the whole thing that it takes people years to get good at it. So that's your job. And so, questioner, you're asking a question. Here's how I hear it. I'm having trouble. And so here's my answer. Your job becomes this. You go shopping until you find a physician or nurse practitioner or a physician's assistant or a prescribing clinical compounding pharmacist who really knows what they're doing. That's your job. And here's the other criteria you need. You need to like them.
Yes.
And you need to trust them.
Yes.
Or you need to at least not dislike them, not distrust them. That's your job. Go find that person. You might have to go through 1 or 2 or 3. It's just like when we go out shopping, sometimes we don't choose the very first shirt or blouse that we see on the rack. We go, I'm going to the next store. And then you go, I think I'm going to go to the next store. I don't really find what I like here. And on the 4th store, you're browsing through the rack and you see that blouse or that shirt that you go, oh my God, look at this. I'm so glad I did the due diligence. So
Right.
it's the end of my time for today.
Let me just interject this. On Tuesday, which I believe is the 28th, I won't be here because I'm in a test. I have my test. And
Oh,
so,
you have your test.
yeah,
So what we're going to do on that day is we will not be doing that day.
okay.
And because we're waiting for you, Carolyn.
Oh my God. Well, oops.
Unless perchance someone comes up that we really, really want to interview, in which case I'll do that day. But we'll let you know, because
Okay.
that's not next Tuesday, is it?
Uh,
Yes, it is.
it is. Believe me, I've been
Say
studying.
no
for it. I
Facebook
know.
Live next
Yeah.
Tuesday.
So I
And we'll be
guess
back a week from today.
on Thursday.
Yeah.
A week from today.
We'll
You know
be
me,
back.
I never know my days ever. They all blend together. I appreciate you. We will be back in our normal spot. You won't see all this mishigas in the back next time. I'm so embarrassed as you're seeing all these extra rooms. Thank you, Dr. Rosensweet, for the amazing answers. Always good to see you. Thank you, ladies, for coming up. Wish me luck on my test. All the prayers, I'll take them all. Believe me. And have a really enjoyable, fabulous, stress-free weekend. Yeah.
Yeah. Good to see you, Carolyn. Good to see
And you
everybody
too.
else. Bye-bye, everybody.
Thank you. See you. Adios.